Hi, this is Joe DiMatteo coming to you again to talk to you about some new topics. Old topics, but new. Why would I say that? Old topics, mammograms, been around for a long time. Screening techniques for women. We've been told, and women have been told forever, that you need to have a mammogram, you need to have a mammogram. I'm not here today to tell you not to or to have a mammogram. I think what I'm here attempting to do is to educate you about some of the downsides of mammograms. We have a tendency to think that because something is recommended medically, that all of the negatives and everything that could be the downside has all been ferreted out and all been separated. And I think that's not true necessarily. And where I'm going to start with is a recent article that just came out within the last few days here in September 2011 that basically said that if you look at some research that comes out of the Scandinavian countries, that what we find is this was 35,000 women in total that were analyzed. And the whole idea and the concept of mammograms, if you will, was to do a couple of things. Number one, improve survival. That's in question. Number two, reduce the amount of radical surgeries, mastectomies, make treatment protocols more effective simply because what we were doing is defining tumors at an earlier stage. The reality of it is that this article piece showed, and this study showed, that there was a dramatic rise in the amount of mastectomies. 31% to be exact. 31%. Let me read you the information. Using National Cancer Data Info for over 35,000 women aged 40 to 79 who were diagnosed with early being the key word, or invasive breast cancers. Oslo researchers found a 31% increased risk of mastectomy in women invited to screening compared with non-invited. In other words, those that were included in continuous mammogram screenings versus those that were not. Now, this, to me, brings out some deeper questions. The safety of mammograms. This particular article was basically saying, look, we thought that the study piece, however you want to term it, we feel that mammograms help to detect tumors at an earlier stage, improve the treatment protocols, improve survival, less trauma, less radical types of surgeries. The literature on balance is really not supporting that, and that's very problematic, number one. Number two, we have the paradox that Len and I have talked about on the radio broadcast over a long period of time, and I'll get to that in a minute. I think that if we really look at this, I think we have to begin to understand that there might be a better way to look at mammograms for women. And maybe not mammograms, but what I should say is more effective alternative approaches to defining breast health in women as far as detection and as far as screening. I'm not going to sit here and say to you that I think mammograms per se have outworn their welcome. But I find what we find in medicine so often, in the radio broadcasts, we discuss this time and time again, what's considered to be acceptable, what's considered to be absolutely correct and right and the most positive thing to do, and you must do this, we find out 5 years later, 10 years later, 15 years later, that sometimes the exact opposite was true. Number one. Number two, you find out that it wasn't what it was all cracked up to be. Medications in particular, we find that to be a chronic issue. But mammograms, do you or don't you? The mammogram paradox showed that women ages 40 to 50 that had mammograms every year, from ages 40 to 50, had a 30% increased risk of ductal carcinoma in situ. We have a lot of false positives that are detected with mammograms. A lot of false positives that then go on to significant levels of intervention, core needle biopsies, etc. I guess my real theme here is to educate you and to encourage the community, the healthcare community, to realize, in my humble opinion, and this is an opinion, that there has to be a better way. I'm not sure that mammograms are cutting it. Let me prove to you another point. BRCA1 and BRCA2 mutation carriers, and in essence, what this means, folks that that have this genetic mutation, BRCA1 and BRCA2, BRCA1 and BRCA2, they're at a much higher risk for developing breast cancer. So for years, what women were told that were at this high risk, that you need to be screened, you need to be screened. Obviously, the screening mechanism, the screening technique is mammograms. Hence, many women went ahead and did that. Here's what we find. Due to the risk of radiation-induced breast cancer, mammography screening for women with BRCA1 and 2 mutations have a net harmful effect. So this is for someone that has a genetic disposition. They have mutations that would make them more susceptible. So follow my reasoning. You're told you are at a higher risk. You should be screened more often because if we define it, we can help you. Well, we find that more mastectomies take place, more radical surgeries take place, not a real net benefit. Number two, in patients that are at a higher risk from a genetic standpoint, we find that instead of documenting, finding, and reducing complications long term, watch this, mammogram screenings that were recommended for women as early as 25 and 30 years of age with BRCA1 and BRCA2 mutation find that now they're at an increased risk. It's not clear what reduction in breast cancer mortality is needed with screening to offset the risks of radiation exposure. Given mammography screenings, we thought that we would reduce breast cancer mortality by more than 25%. The authors believe that the harms, watch this, of annual screenings outweigh the benefits, especially in women aged 25 to 29 years of age, probably also even in the 30 to 34-year-old age, because only the older women find a net apparent likely benefit. This is from the Journal of the National Cancer Institute in 2009. So once again, what are we trying to tell you? We have to be wise. We have to find out and we have to seek information. Women that have been told time and time again that if you're at a high risk, if you're BRCA1, BRCA2, you start them early, 30 years of age. Now we're finding net benefit is not there because of the radiation exposure. We also find that if this article that comes out of Norway and out of the Scandinavian countries, done by some researchers in Oslo, 35,000 plus women analyzed, 40 to roughly 80 years of age, early invasive breast cancer. Instead of reducing the amount of trauma, improving treatment strategies, excuse me, 31% increase in radical mastectomies. One of the physicians makes a comment in that article that says, well, mastectomies are not as bad as they used to be. Reconstructive surgeries they're so much better today. I find that almost a foolish, rude comment to make. Radical mastectomies are radical. Actually, they don't use that word. I put the word radical and they use the word mastectomies. I use radical. The bottom line is annual mastectomy rates rose by 9% in those that were screened, fell by 17% in those that were not invited for screenings. In other words, those that were not screened. You say, well, then you're advocating not screening. No, what I'm advocating is that we look for better options. In my next teaching here, I'm going to cover a little bit of a generic background on how to improve breast health. I'm Joe DiMatteo of the Len and Joe Ask the Pharmacist broadcast, heard on XM, Sirius Satellite, and local stations possibly near you and in your area. I'd encourage you to go to our website, lenandjoe.com, and tune into the radio broadcast. Go to the website, lenandjoe.com, for further teachings in this area. Thanks for being with us. Tune in for the issue on breast health. Thanks. Have a great day.